So for those who haven't met me before, I'm Rachel Forbuster. I work for Health Innovation North East North Cumbria, and I chair this wonderful digital inclusion forum that we run about 5 times per year, but we also look and explore any opportunities for collaboration and work that might fall out of this wonderful forum. So just to go through some housekeeping rules, we are obviously make sure you're on mute, although Yo-Yo will monitor that. We are recording the event, as I've mentioned, so that we can circulate after the event, but that's also for those who've registered and have been unable to attend. You will also find the recording on the Boost Learning Academy. If you haven't already registered, we've covered that as the last topic, but please do, because you'll also get information through that route. CC captions can be turned on at the bottom of your screen. And please do use the chat function throughout to ask any questions as we go, and Yo-Yo and I will monitor that really closely. So for those of you who are new to the forum, you might not know what a health innovation is. We are one of 15 across the country, formerly known as the Academic Health Science Network, and we were established by NHS England in 2013 to really look at how we spread innovation at pace and scale, and how we really make a difference to the population health as well. So what we try to do is connect the partners in the system. So we've got a number of those on today from different backgrounds. That covers academia, NHS, innovators themselves. So we certainly work with innovators from one-man band to a bigger organisation who has an idea, as well as local authorities, third sector, regulators, and so on, an awful lot. And on the right-hand side of the screen there, you'll see the makeup of all of those health innovations, but also our 3 priorities around transforming patient safety, about improving population health, but also about generating economic growth and how we keep that money within our system. It's just to share a little bit about who we are. So today I'm delighted that we're joined by 4 wonderful people. We've got Bethany, who will be last on the agenda, who's the Training and Benefits Lead for the Great North Care Record. That's about being able to see a summary view of your record. She's going to provide some brilliant updates on some future horizon things. We're also joined by Maria Williams, Deputy Director of Digital Programmes and Governance, and her colleague Rebecca McIntosh, who's the Head of Digital and Infrastructure. And they're going to be covering off kind of the launch of the Digital Inclusion Strategy, which the ICB have pulled together over the last 12 months. So I'm absolutely excited to hear about its progress and as it moved in from draft to final stage. And then we have brilliant and entertaining John Quine, who's Head of Programmes, and he's really focusing on healthcare inequalities, and he works for the next North East Commissioning Support. But before we move into that, just want to very briefly touch on something that was launched as a draft in February for comments, and this is all around the government's Digital Inclusion Action Plan, and we're making sure everyone can be included in our digital world. So this is what they have set out. They're focusing on 4 key areas. So firstly, opening up opportunities through skills, tackling data and device and digital poverty, breaking down the barriers to digital services, and finally, building confidence and supporting local delivery. I think it's really important to set that scene, because that's obviously the digital inclusion strategy for our own region will pull some of those areas into it. So over the next key 5 years, they've identified the top 5 actions. So one is around potential innovation fund pot, which will really help local leaders to support some great innovation. Enhance support of the framework that helps people and businesses to get essential skills so that we can actually stay online, but do that in a very safe way. Pilot a proof of concept multi-department device donation scheme. So they're looking at working with the Digital Poverty Alliance, who we've formerly had speak at this forum. So we're looking at exploring that and supporting that. Making sure government digital services are easier to use with a renewed focus on digital inclusion. And for me, this title of ours is making sure no one gets left behind, and that's got to be our focus as we move forward. And finally, measure what works on digital inclusion and try to measure that about upskilling adults and digital skills. So we're going to move on to Maria and Rebecca. So I'll stop sharing my slides, and it's over to you guys to tell us all about your programme. That'd be fantastic. Sorry, I couldn't find my stop sharing screen.
Thanks, Rachel. Hopefully that's sharing there. Is that sharing?
It is sharing, Maria, but it's kind of sharing with yourself for me. I don't know if this is all right for everyone else.
Let me try
Just,
again.
yes.
Did it have the slideshow on there, Rebecca?
It did, yeah, it did. Yeah, it's on
Sorry,
there.
is
All
that
right
sharing
for
now?
everyone?
Yeah, great. Thank you, and thanks for that lovely introduction, Rachel. So as Rachel said, I'm Maria Williams. I'm the Deputy Director of Digital Programmes and Governance for the North East and North Cumbria Integrated Care Board. I also have the pleasure of being the Deputy Chair for the North East and North Cumbria ICS Digital Inclusion Steering Group. Do you want to introduce yourself, Rebecca?
Yeah, thanks. Yes, I'm Rebecca McIntosh. I'm Head of Digital Infrastructure for South, which covers the Tees area of our region. I'm also lucky enough to have been involved in the digital inclusion strategy when we went and worked with our digital inclusion steering group to go and pull this together for our region. So I'm really excited to be given the outcome of that today.
Thanks, Rebecca. So we're here today, as Rachel says, to give you an update on where we are with our regional digital inclusion strategy and some of our journey of how we've gotten to where we are. Please tell me if this doesn't move on, but hopefully it has. So just a slide on what does digital inclusion mean. So in essence, it's about providing everyone who is able and interested with the choice to access and interact with digital technologies and services. We need to recognise that when we introduce new services digitally, that we can potentially create barriers and add to inequalities for those who are not currently digitally connected, and indeed those who choose not to connect digitally. And we need to ensure that no one is left behind as we introduce new digital services. So, as I'm sure many of you will be aware, across our region, our population has a greater likelihood of health inequalities. These include higher rates of mental health illnesses, higher rates of suicide, and certain diseases such as cancer, heart disease, and respiratory disease compared with national averages. And overall life expectancy across our region is lower compared to national average. We also have approximately 35% of children in our region who are currently living in poverty. So we must ensure that when we introduce new digital technologies, we don't add to those inequalities. Across our region, there's around 6% of people who don't have an internet connection, which equates to around 30,000 households. There's also around 9% of adults in our region who have never used the internet, compared with 6% nationally. And across the UK, there's around 10 million people who are lacking basic digital skills. So we believe that through addressing such barriers like digital skills and access to technology, and indeed how to use digital services, we can enhance the services for our citizens and our workforce, including improving access to health and care, improving the health and care outcomes, driving cost efficiencies and creating more cost-effective ways of delivering services, and enabling targeted interventions. We also believe that if people engage digitally for their health and care services, they're more likely to engage in other online services such as job seeking, housing, social interaction, banking, etc. So we believe that it could make a more positive impact on the wider determinants of health. So what are we doing? Some of our progress to date. Our journey actually goes back to, it was around August 21, when the National What Good Looks Like framework was released. So in the North East and North Cumbria, we developed our own self-assessment tool and assessed ourselves against that framework. Two big gaps that came out were digital inclusion and citizen engagement, and that we identified that this is something that we needed to do more engagement on, and actually set up a steering group. So in December 22, we stood up our region-wide digital inclusion steering group. The group now has upwards of around 30 members, so from across health care, the voluntary care sector, industry, colleagues from Healthwatch, and so on. And it is chaired by Steph Downey from Gateshead Council. We meet about every 6 weeks, but really proud of the work that the group have done and how it's kind of evolved since December 22. We've done a lot of regional engagement. So with our steering group members, and also through surveys and workshops and presenting to lots of different groups and forums to kind of set out our approach to the digital inclusion strategy. And we've agreed our regional digital inclusion strategic vision, which is to ensure that all people and employees have equitable access and understanding of digital technologies, allowing for a more accessible, efficient and effective health and care system. And we have developed our first North East North Cumbria digital inclusion strategy, as I say. The really good news is, following our significant rounds of regional engagement, the strategy was tabled at the ICB board in public last Tuesday, the 3rd of June. It's streamed on YouTube, so if anybody was interested, we could provide the link to that. And Professor Graham Evans, who is our Chief Digital and Infrastructure Officer, presented the strategy and it was approved and got some really excellent feedback from the board in public. We've also, along the way, managed to secure some funding to support a number of projects, some of which have been delivered now and some of which are well underway, which are aligned to the delivery of our strategy. We have strong links with the Healthier and Fairer programme, and indeed a lot of the funding that's come through has come through Healthier and Fairer, but also from other avenues. So we're always kind of looking to see where there's any opportunities to apply or bid for any funding in support of delivery of our strategy. I've probably done a real whistle-stop tour there, and there's probably lots that I've missed out, but I'm going to just show you just how the strategy is shaping up. Once it's been published in the coming weeks, I'll provide a link and you can have a look at the final version. But it goes through a foreword from Professor Graham Evans and Steph Downey. We go into some regional context, local context. So this strategy is very much an underpinning document to our regional digital data and technology strategy, but also our better health and wellbeing for all strategy. It goes through some national context, our vision, our themes, and that's just to kind of give you an overview of what it's looking like. So I'm going to hand over to Rebecca now just to talk us through our initially our 5 key interlinked themes. Thanks, Rebecca.
Thanks, Maria. So thank you. So what I'm going to do now is I'm going to talk about the 5 key interlinked themes, which are very much at the heart of the strategy and sort of all of the work and projects and programs for the future and roadmap really hang off these themes. It's worth saying that the information that Rachel gave at the beginning of this forum around the government's digital inclusion action plan, those priorities and focus areas really do align back to these themes as well as the NHS action framework for action, where there's 5 domains for action. Again, they all link back. So you're going to hear some in various forums, a lot of discussion around digital inclusion themes and actions, but really what we've done as a region is made sure that these themes here really link back to the national programme of work and the national priorities as well. So first of all, we have access to devices and data. And again, that'll seem really familiar to one of the focus areas that Rachel mentioned earlier. And this is around how we as a region can make sure that everyone who chooses to get involved in digital has access to a device by which to do so. And not only any device, a device that is appropriate and is able to support any technology that we, as a health system or as an ICS system, ask them to get involved in. And not just having that device, about being able to use it, having access to data or strong and effective Wi-Fi. We're a huge region with a lot of different areas, so from country to city. So we need to make sure that all of those sorts of things are considered as well. Accessibility and ease of using technology. So this really is about making sure that the user is at the centre of everything that we do, that we think about co-design, and we think about digital inclusion throughout the process of everything we do. And when we build, not only when we're bringing in a new digital technology, but through the life cycle of that, and really continue and assess it. And it's not just a sort of a tick box exercise at the beginning, it's something that we do all the way through. Skills and capability is really about both workforce and users having the ability and skills to use digital approaches to health services and being able to respond to people's different levels of capability. And again, assessing that things are changing so fast in the digital world that we need to constantly be on top of that and making sure that the change in skill is in line with the change in support that we need to give. Belief and trust, so people understand and are confident using digital health approaches, and this is really key. There's one of the parts of our vision is that people have the choice, but also that they make an informed choice about understanding what risks there might be, for example, to their personal data, alleviating any fears around that, and making sure that people have the confidence and they trust the technology that we're looking to implement. Leadership and partnerships, and this is really about having a coordinated approach to reducing health inequalities, and we're going to hear from John later today, and it's about linking in all of the work that digital inclusion does and how that links to things like poverty proofing and health inequalities more generally. And that way, not working in isolation as a health system, but we're also working with our partners in VCSE, in local authority, and any other system that is appropriate. So we're really working through that together. So next slide, please. And so what we're looking to get out of this. So this is some examples of some things that we hope to hear from both our patients and our workforce around what the benefits of digital, making sure that digital is at the heart of everything, and that we're considering digital inclusion effectively. So it's about choice, having the choice to use digital solutions, that it is an option for everybody, not just those who might have access. That people can know where to go to get some free data and to use social tariffs for broadband, that there is a clear signposting pathway for that. Being able to view your health records online. There's a lot of talk about the NHS app. People are almost inundated with information in the press and the news and everywhere about that at the moment, but understanding what it is and how it can support individuals. And I'm going to talk a little bit more about that shortly. That people can see that digital inclusion work happening in their area, and they know where to go to contact. There's so much brilliant work going on in local authorities, and it's really about making sure that those offers are taken up and that people understand what they are and where they are. For health workforce, it's about patients having the opportunities to interact with different pathways using digital tools, keeping one of the government shifts to keeping people at home. So it's sort of hospital to community, and the effective use of digital tools is something that will be absolutely paramount in meeting that aim. And it's on confidence for staff, so in workforce, so making no assumptions about anything, but also supporting staff in improving their digital ability and their knowledge so that they can support users in turn. And helping patients manage long-term conditions is a really great example of that. So really giving the empowerment to patients so that they're able to manage that, feel that they're in control of their care as well. Next slide, please. So I mentioned earlier about being inundated in the press, and this is a really, really recent one, and something that I've been thinking about as I've been sort of reading the press myself. And one of the three shifts, so I'd mentioned one earlier around hospital to community, but the big one around digital is analog to digital. And so how do we move into a digital world in the NHS, and how do we ensure that digital inclusion's at the heart of that? The screenshots below are literally from the same day, and these are different messages through different mediums that are being passed out on my phone, everybody's phone. So from around the NHS app, which is a key government priority and a key priority within healthcare to really save money, put money back into frontline services, and around it really is the way that we are looking to go. So this is a bit of a message really to show this is what's going out to to our people within our communities across the northeast and North Cumbria. And this might be quite worrying or concerning for some people to say, there's pictures of phones everywhere here, there's the word app here everywhere. You're going to get things on your phone. If you're not if you don't feel digitally included, this could really trigger something within you to be concerned around how you're going to move forward with this. What does this mean for me? What does this mean for my healthcare? What does this mean ultimately for my life? So on the next slide, what we'll see is a bit of a temperature check that we're taken directly from those stories, taken off names, but if you so wish, I'm sure you can find this. It's all publicly available. But these are some comments that people have made on those stories. So what we see here is really the living and breathing concerns and comments and temperature around digital inclusion. So question 1, what about the elderly? Response, I'm 82, no problem. So what we're seeing there is really about choice and about making no assumptions. So yes, elderly people might be one of the at-risk groups of digital exclusion, but not always. Now, somebody's I'm 82, I embrace this isn't a problem for me. What about people who don't have mobile phones? Absolutely, and that's at the heart of the devices and data theme. I get my appointments for the eye hospital via a portal and I confirm, I get a reminder, works well. Brilliant, advocating for, this is going really well. But also what I hear in that is that somebody's getting something through a portal and they're now concerned or confused about, will that continue? Will I need to use an app now? I need that's a different thing. Here's quite a negative one. Good luck with that. Plenty of people, especially older amongst us, were brought up not to think that the world revolves around a tiny computer screen. And again, that one goes back to choice. How do we make sure that this is a choice? How do we make sure that those who wish to receive appointments in a particular manner have the ability to do that? Have you asked? That's around collaboration and listening and around making sure that patients are at the heart and of everything that we do around design. One here about saving 200 million a year is not to be sniffed at, absolutely not, and sort of understanding of why this is happening, but also recognizing that some people won't or don't really want to go down that route. Differences in the app, joining up systems. It really could be any meeting of digital in any ICS or around the country, I'm sure, but really gives you an idea about where the public are with us on this journey. Again, it's temperature check. It's literally one day, a few articles, but I thought it really linked well to one particular part of our strategy that we are implementing and one particular key tangible thing that we want to be able to make available through the strategy, and that is the digital inclusion design checklist. And I want to talk a little bit how we've designed this. So this is a tangible tool that we have designed through our steering group. We set up a task and finish group. So it was produced in collaboration with members of the Inclusion Steering Group and others who came to our event in September last year around the strategy and around gaining feedback and information. It's a document that is going to be embedded within the digital inclusion strategy and is really a core part of that. The document itself and the checklist itself was built on work that had already been done in other ICS areas. So we're really keen to not reinvent the wheel all the time and really look at what's been effective in other areas. And this is a great example of that. So from colleagues from other areas of the NHS shared with us some work that they had done around a checklist tool. And we built on that and worked in our task and finish group to make it appropriate to the North East North Cumbria. It doesn't replace anything. It doesn't replace any existing legal assessments for equality and inclusivity. It aims to build on that and guide thinking. It's a tool which can grow and evolve. We can change this, we can add, we can take away. But it really is a tangible document that aims to take digital inclusion from theory to practice, from strategy to practice. So it's a document that guides thinking at the inception of any digital implementation that might happen, but also that can be picked up to review any digital implementation that may be in place to make sure that it is inclusive and it does consider digital inclusion at the heart of that work. There's a little screenshot to the right there of a part of the document itself. We'll share this. It's sort of being worked through still to a degree, but we are going to sort of share that very shortly with the strategy. So what is it? What sort of things does this tool guide users to look at? So first of all, it looks at who is going to be affected by this transformation or this new digital technology. So is it the public? Is it the patient? Is it the workforce? Is it all three? So we need to be, because that'll guide our thinking as well. What involvement engagement has been done in relation to this? So have we spoken to relevant stakeholders and different groups to make sure that everybody's considered? So if we think back to that temperature check, have we asked the users, the people who are going to be using this, have we spoken to them about it in any way? And what are the arrangements for monitoring and reviewing the actual digital inclusion impact? So what's happening next once we've done this, and we're going to make sure that we continue to do it. It asks questions. The document asks questions of the person completing it to ask them, have you considered, have you thought about all of different elements of digital inclusion before you put this this new digital technology in place? But what I've done here is I've taken some of the questions that are asked and sort of to give a flavour of this document. So it asks questions around protected characteristics. So thinking about, are there any religious, cultural or ethnicity matters that need to be addressed? Will the recipient or the user of the technology have cultural barriers to using digital technology? All sorts of different things and different following questions around that, but that's something that we feel is really important and key for digital inclusion. We're asking questions around materials and technology. For example, where does the kit come from to access this technology? Is it something that's provided by the supplier, or are we asking people to use their own kit or computers or laptops or telephones at home? What's the affordability of that? Will it drain people? Will that take a lot of people's data? Will it be a drain on people's networks? We need to think about that. We need to think about backward compatibility. Digital technology really moves at pace and new versions are released all the time. And that's really great and it makes things better. But sometimes that excludes people at source because some technology isn't compatible with older devices, for example. We need to think about things like visibility. So just because it can be on in a mobile phone, it doesn't mean that that's the best usage of it. Can people see that? This really important health data, for example, effectively on a small mobile phone screen, or is that something that's better viewed on a different technology? Access, will it require use of internet? What's the data signal like? Will the recipient be able to access any free broadband? Can they afford to pay for this additional requirement that this technology could bring online into their lives? The home environment, and this is a really important one, but do people live in multi-occupancy residences? Do they have private locations to discuss the health matters? Or is this something that we need to consider? If we're moving away from really private healthcare rooms where you can, where there's, sensitive matters can be discussed, and asking people to do that from the home, we need to consider that people have the ability to do that. Space, privacy, connections, electricity supply, safety. There's safeguarding considerations that we need to consider as well. The workforce, how do we help them to deploy this new technologies and new digital requirements? Do their levels of skill need to be supported? How do we train them ongoing? What do they do when users come to them with questions or concerns? How do they signpost in for support for digital inclusion? The skills of the patient. Have we asked the users to test it, or have we just implemented it? Is it intuitive? What level of skill? I think the average reading age in our region is, I think it's 9. I'll happy to be corrected on that, but we need to consider the literacy level, the health literacy level of within our region, and make sure that any digital technology considers that too. Safety and safeguarding. Often devices are used by multiple people in a household. there's some private and confidential things that people need to discuss with healthcare providers, that we need to consider the accessibility of other people in the household and translation needs. Again, these are just some examples that I've taken from the checklist toolkit to share with you, just to give a flavour of what that tool is looking to do and the questions that it's looking to be asked. And this is for people who are implementing or have implemented digital technologies, to really consider these things, because it's great to implement digital technologies. It's really exciting and it can really save a lot of money, and it can be, all these brilliant things that digital can be. But sometimes we need to take a step back and check ourselves and use it. And this tool really aims to do that, and to be able to consider and make sure that we're improving the lives of people by digital, by making sure that everybody, again, who chooses to, has the ability to utilise it. Thank you. So I think I'm going to hand back to Maria now to talk about where we're going to take the strategy next.
Thanks, Rebecca. That's great. Thank you. So hopefully this moves on. So some of our next steps, as I said, the strategy was signed off by the board in public on the 3rd of June. So we'll be looking to get that published as soon as possible. We've tried to keep the document itself as jargon-free as possible, as we did with the design of our digital data and technology strategy. So it's very much in the same style, but we do appreciate that it's not as accessible to everybody as it could be. So we are going to be looking to work with health literacy colleagues around an even easier read version. As Rebecca says, the average reading age, I think I've heard the figure 7 before as well, so I'm not sure if it's between 7 and 9 years old in our region, but we just want to make sure that the work that we're doing and setting out to do is as accessible as possible to our public. As Rebecca's talked through, we're looking at further developing and publicising our digital inclusion checklist tool, and there's lots of work going on at the moment, including with Healthier and Fairer programme colleagues around the planning and delivery for 25-26. So this last slide just kind of illustrates that our strategy, for it to be successful, it can't be delivered in isolation. It's something that's going to evolve and keep on evolving over time as things move on. And we need to focus on designing and delivering accessible services enabled by digital options, as well as supporting those who choose not to interact digitally to have access to the same services. As I say, we need to recognise that digital isn't a choice for some people, and make sure that they're also that they have equity in the delivery of their health and care needs. And as I've said, it does need to continuously evolve, and we do need to embed those digital inclusion principles by designing all organisations via the checklist tool. So hopefully we've kept to time. That's us, and thank you very much for your time this afternoon. I'll stop sharing now.
Well, fantastic. Thank you so much, Maria and Rebecca. I think for me, it really resonated, all the content you've talked about. But what you managed to do in your presentation was give that high level strategy, but then turn it into reality about what it means to me as a patient, as a person, as a citizen. So I'm really pleased to see that you've got that message across, because I'm sure our audience would have really kind of appreciated that. That's about what makes sense, doesn't it? And about keeping the people, and keeping the people at the heart of what we do. And that wasn't just about patients, but I guess you've touched on the confidence of staff as well. So you've got to think about, it's not just digital inclusion from that perspective and engaging with services, but also about the workforce. So that was great. And I love the tool. Can't wait to get it out and see it and use it. So we've got a couple of comments, a couple of questions from myself and a couple from our audience. So my first one is, what's your advice to the audience about the strategy? I know you want them to go out and shout about it, but what's your top couple of tips on what you'd like to see people do with it?
Yeah, so we really, the strategy is our regional strategy. It's the integrated care system. As I said, it's been developed in collaboration with a wide number of stakeholders, and a lot of people have had input and involvement in it. So what I would really like is for people to read the strategy to understand what it is that we're setting out to do and why we're setting out to do what we do, and then to really fly the flag within your own individual organisations. We don't expect that everybody will be able to deliver all of the strategy, but there'll be some elements that will resonate with some people and with the work that they're currently doing. So it's about really taking it and adapting it to work that's either already underway or in the planning, is what I would say. I don't know if you've got anything to add to that, Rebecca.
I think one of the really great things that people will get from the strategy is looking at the work that's all underway and the work that's in flight across the region, and being able to either link into that work if that's something that's relevant to the work that you do, or to build in additional to that. So what you'll see in our strategy under the 5 key interlinked themes is what we have done as an ICS region, some examples of that, and what we will do, and a roadmap as well to say these are the big pieces of work that we want to do. So if there's something that resonates with you that you'd like to get involved in, or if there's something that you think actually the work that we do really aligns to this and you'd like to be part of the steering group to sort of learn more, I would encourage people to do that. It really is a multi approach within that steering group, and Tony Clayton, who is heading that the Digital Inclusion Project Management Office, is always keen to make sure that we've got really great representation on there. So reaching out to Tony to say, you know what, I've looked at the strategy and I think the work that we do is part of it. I'd like to be part of the work that the strategy is delivering moving forward. I think that would be something that people might get out of it too.
Brilliant. You've kind of covered my next question already, which is about the plan to communicate the strategy wider. But I was going to ask you about how your members can help. We've got 40 odd people on today. Can they add it to their website? Do you want them to include it in their newsletter when it gets launched officially? So anything that they can do really to help facilitate the dissemination of that and what it means to our audience.
That would be fantastic, Rachel. So once the strategy's been published, it'll be on the ICB website, and then we can supply a link, and feel free to paste that link into any way at all that we can share the message as far and as wide as possible, is what I would say.
Last question is around staff and workforce, which I've touched on already. Certainly the forum is one of those routes that people can come to learn and share. They contribute themselves, which is really brilliant. But I'd like to hear from you guys about also, making every contact count, what we're doing to tackle that workforce as part of the digital strategy, and are there any emerging ideas that are falling out of the strategy to help that?
Yeah, it's early days in terms of, there's obviously, we've got a lot of work going on the Boost platform, which is everybody should be able to get access to. But there's some work to be done in terms of the workforce digital strategy as a whole. And that's, I believe, unless anybody corrects me, I think that's some national work. Obviously, there's a lot of huge scale, I would say, organisational change going on in the NHS at the moment, and with our integrated care board. So there's a little bit of uncertainty around where this will land in terms of ownership of delivering the strategy and oversight of that moving forward, but we're hoping to work through that in the coming months. In our recent digital inclusion steering group, Graham Evans provided an update to the group to say, just to say what I've just said, really, that we are going through a lot of change, but that we need to keep on going with the ICS digital inclusion strategy. It is such an important agenda. So I'm sorry I don't have the workforce answers at this point. I don't know if there's anything that you can add to that, Rebecca.
Just to say that the strategy is a real collaboration effort, and is sort of, I would say it's multi-owned by all members of the steering group and interested people across the ICS. So being part of the steering group is key to keep up to date with, joining up best practice, sharing practice in your organisation, and understanding how that links strategically to the document that we've been discussing today. And I think that's something that it would be a really key source of information for people moving forward. Because, and one of the things that sort of was really telling is when the strategy got signed off at the board in public last Tuesday, that was a comment that was made by a member of the board to say, this was a collaborative effort and people really feel part of it. And that, I think Maria and I were really, really proud about that, to sort of say, this isn't a strategy that we've written in a dark room. It's a strategy that's been built upon the amazing work that goes on across this region already and builds upon that. So being part of that steering group which formed that is probably, it's the place to be, I would say.
We've got a couple of questions from our audience, which are going to be quick because I'm conscious time and I'm not sharing as brilliantly as I could do, but then there's lots to learn, which is always good. So we've got Mary who's asking about the checklist, but you've mentioned the checklist will be launched at the same time as it goes out onto the platform. So Mary, you'll just have to wait a little bit more patiently for that to come through, and we will circulate it to the members of our forum as well, so you'll get it through that route. We've also got one of our academics on the call today, and she's doing a big research piece, and she's kind of asking about how she would enable kind of a survey to go out to people in order to collect some really rich information. So I don't know whether you've got any insight into how she might do that. She's talking about medical assistants, GPs, asking for medication, etc. And just if there's any advice or guidance you can give her around that.
Yeah, happy to link in offline
Mm-hmm.
on that one. I'll put, and I know there's a number of other queries that we might not be able to get to, Rachel. So I'll put my email address in the chat.
Wonderful.
And if it's not myself, I should be able to signpost to the person or the people or the team who it is.
Great. So Violet and Sandra, if you could reach out to Maria, she'll get a response for you on those two. And we will move on. Any other questions that haven't been answered, we will follow up and get back to you afterwards. So we're going to move on to John Quine. So John, thank you very much for joining us. Would you like to share your slides?
Thanks, Rachel, and thanks also Maria and Rebecca. And I'm hoping that the work that I'm going to talk through builds very much on the strategy and the approach. My name's John Quine. I'm the head of programs for healthcare inequalities within the Integrated Care Board's program called Healthier and Fairer. And so within the healthcare inequalities work that I lead, we have 7 projects, including the Deep End, Inclusion Health, that we're going to be talking about today, Core 20+5, Poverty Proofing, Health Literacy, Social Prescribing, and Digital Inclusion. And all of these pieces of work are focused on reducing those avoidable inequalities that we know are unfair and unjust. However, I think at times it feels like as a system, we're trying to ride 2 horses with one rear end, if you forgive me for saying so. We have that focus on system performance. We're all being asked to do things more effectively, more efficiently. We talk about demand management, and we manage this through contract performance and performance management. And it's a political imperative. It's always in the news. How can the NHS improve its performance? But the other horse is that of population health. And that's about population profiling, understanding the health and the needs of our community, and doing that through engagement by genuinely listening to their needs. It's about population health outcomes, and it's here that we start to think about health and healthcare inequalities. And for those of you with a professional registration, such as myself, it's also a professional obligation. So we have to ride these 2 horses at the same time. Now, within the healthcare inequalities space, we talk about inclusion health, and it's not a term that I'm particularly comfortable with because I don't think it's accessible. I don't think it means anything to anybody when you hear the term inclusion health. You could say it's not a very health literate term. But what do we mean by this is that it's an umbrella term, and it's used to describe people who are socially excluded, and they typically experience multiple interacting risk factors for poor health. And this includes stigma, discrimination, poverty, violence, and complex trauma. And we know that people from these communities suffer inequalities in terms of access, uptake, experience, and outcomes of healthcare services. Now, you may still be left wondering, well, who is it that you're actually referring to? Well, within the North East North Cumbria Integrated Care Board, we have identified these 17 communities or groups. I'll just give you a minute to have a read through them and see whether or not any of those groups you'd be surprised at, or whether or not you feel that we've missed any off. What's really, really important here is the notion of intersectionality. And what I mean by that is that people are very, very rarely a member of one group alone. So we know that, unfortunately, many people experiencing homelessness have also served in our armed forces, and they may have serious mental illnesses, as well as having substance misuse challenges. So whilst it is a list, we really need to remember and reflect that people are unique, and their challenges that lead to the inequalities that they may experience are often multifactorial, and when people are not just members of a group on a list. So why is focusing on the needs of these groups important? Well, this graph, forgive the sciencey bit, is called the standard mortality ratio of inclusion health groups. And what that is, it's a way to see if a group has more or fewer deaths than expected after adjusting for differences like age and sex. Now, what we have here, this line, this almost flat line, is what we call the social gradient. And we know that more disadvantaged areas have worse health outcomes than more affluent areas. And we often talk about the differences between the most deprived and the least deprived communities. Well, that big box on the right-hand side is not about the social gradient. That's the communities that I'm describing here, the inclusion health groups. So what this is essentially saying is that whilst they may be fewer in number, people from inclusion health groups have significantly worse health outcomes. By means of an example, the average age of mortality of death of a woman who experiences homelessness is 46 years. For a man, it's 48 years. Now, that's one of the few health indicators or outcomes where women fare worse than men, but 46 and 48 years of age is worryingly bad. So there are a whole range of really poor health outcomes that people from inclusion health groups experience, and that's why it's so important that we focus on these needs. So within our work, we took a national policy, the must do, to focus on inclusion health groups, and we co-produced an approach called Our Approach to Inclusion Health. Now, that approach was undertaken, like I say, co-produced with the voluntary and community sector from all of those different communities that are on that list, with academics who are working in research and evidence with these communities, and with NHS teams and clinical leaders. And we established these 6 principles that we believe, if are applied when considering the needs of inclusion health groups in whatever service you may be working within, you will be better placed to support the needs of inclusion health groups than if you weren't. So the first is trauma informed. We know that people from inclusion health groups experience trauma, but do we reflect this trauma in how we deliver our healthcare services? Are our staff adequately trained, and do they understand what it means to have experienced trauma and how that can impact on people's health-seeking behaviours or their experience of healthcare when they receive it? And how can we support people in our workforce in delivering trauma-informed care? So taking it out of the specialist mental health service arena and bringing it into universal healthcare. The second principle is that everything that we do will be research-led and evidence-informed. We have some of the best universities in the country here in our region who work with communities of disadvantage and who experience stigma and discrimination. So there's a whole community of brilliant researchers who are working on producing high quality evidence. And we need to take that evidence base and then translate that into policy and practice. The third principle is data driven. So the NHS collects an awful lot of patient information, loads and loads and loads of data. But people from inclusion health groups are often hidden from the data sets. But where data does exist, we must leverage it sensitively in order to support people from inclusion health groups. And I'm going to give you a little example of that. I was working with the Mission for Fishermen in North Shields, and they tell me that they had been working with their GPs. And they said, you do realise that all of our fishermen are registered in your PCN, in your collection of practices. And yet the GP practice were not identifying them on their system. They weren't coding them as fishermen. They didn't even know that there was a code for fishermen, but there it was. That meant that the needs of that community were hidden. We couldn't extrapolate the information. So using the data sensitively is a really, really important part of our approach. The fourth principle is that we must do this with people with lived experience. We must not do to communities, but work with communities. And that's where engaging with the voluntary and community sector who are working with inclusion health groups is really important. Often in the NHS, when we work with the voluntary and community sector, it's with those organisations that align with the clinical service that we're working with. For example, if we're working in cancer services, we'll often have really good links with Marie Curie or Macmillan, but maybe not with a Roma and Traveller organisation. So it's about challenging some of those preconceptions about who are the voluntary and community sector organisations who we need to work with in order to understand the experience of people from inclusion health groups. Fifth principle is that we must undertake this work recognising the family and support network. Now, people from inclusion health groups don't always draw upon their next of kin necessarily as their support network. They may have good support from their family, but they may also associate themselves and draw strength from different communities that they wish to identify with. So it's about challenging the preconception that next of kin equals support network. It doesn't always mean that. And the sixth and final principle is parity of esteem. So this isn't parity of esteem necessarily between physical health and mental health, but it's recognizing that healthcare is a universal right. So it matters not your background, your experience, anything that may have that identifies you as a marginalized community. You are equitably entitled to healthcare. So let's ensure that no one in our community, no matter what their background is denied access to high quality care. So when we have a think about the digital inclusion framework that Rebecca and Maria have just been describing and the principles of inclusion health, I'm hoping that we can see some significant commonalities and overlap. And what I'm hoping is that just as much as the work that we do in inclusion health will always consider a digital inclusion component, I would hope that every single piece of work within a digital inclusion space consider the needs of inclusion health groups. And I think that we have, through the work stream and the collaborative way of working across the system, not just the opportunities, but very much the passion to ensure that that occurs. So, how do we ensure equity in every click? Trying to bring that together. I think the first thing is recognizing what I was describing before, the multiple disadvantage or the intersectionality of inclusion health. So people in inclusion health groups often face those multiple and intersecting disadvantages such as poverty, homelessness, disability, language barriers, low literacy. And digital exclusion frequently compounds these inequalities. So, for example, a person experiencing homelessness may lack a device, data, and the skills of a safe space to access the digital services, and that can further isolate them from healthcare. I think the second thing is beyond technology, those human connectors. So whilst digital technologies offer significant benefits, they should not replace human interaction or limit face-to-face appointments. That goes back to the issues of choice that Rebecca and Maria were describing. I think for inclusion health groups, trust and personal relationships with healthcare providers are often paramount, and purely digital solutions can further alienate them. Thinking about some of those barriers that are just beyond cost, but it does include affordability, and we know that the cost of devices and data is significant, and the repurposing work, I think, is absolutely brilliant and a phenomenal enabler to address both digital exclusion and support inclusion health groups. We know about the issues of connectivity, the lack of reliable internet and access, and this is particularly keen in rural areas or for people who are unable to afford it, or both. Skills and confidence, and many people from inclusion health groups lack digital skills and confidence needed to navigate online health services. And this is a direct digital inclusion barrier that impacts their ability to access care, making them an inclusion health concern. Lastly, in this section, accessibility. So digital services must be designed to be accessible for people with disabilities, cognitive impairments, or those with limited literacy or English as a second language. So if not, they exclude these individuals from health information and services. The capability of the workforce in regards to both inclusion health and digital inclusion is really important, and we need the right staff with the right skills and the right understanding. And this includes digital literacy for staff to effectively guide patients to online resources, as well as the awareness and training in trauma-informed care, cultural competence, and an understanding of what it means to come from an inclusion health group in regards to healthcare, to effectively reduce those barriers and reduce the inequalities that often people from inclusion health groups experience. Just turning back to data and measurement. So both inclusion health and digital inclusion approaches require the collection and use of data to understand who is being excluded and why. It's got to be done really sensitively, though, and we know that people are feeling particularly vulnerable about sharing personal information, and then there's an awful lot of mistrust around how data is used, but particularly personal sensitive information when we're considering inclusion health groups. And we've got to recognize that one of the common challenge here is that people from inclusion health groups are invisible in those data sets, and this can be due to their transient lifestyles or difficulties with registration, and this can further perpetrate the exclusion from digital design and evaluation. And lastly, discrimination and stigma and the negative past experience can lead to a profound lack of trust in services amongst inclusion health group. This distrust can extend to digital platforms if not managed carefully, with concerns around data and security, as I've just described, being very prominent. I know Maria mentioned before about the Learning Academy. I would strongly encourage you all to go and have a look at the Learning Academy site, where we have not only a section on digital inclusion, but a whole section on healthcare inequalities, where more information regarding the approach to inclusion health can be found. It is open access. You don't need an nhs.net email address to access that. So do please register for it. Go and access the materials on there, and I'm hoping that that will support your journey in reducing digital barriers and improving the experiences of inclusion health groups. And just finally, rather than riding two horses, I hope that through our endeavours we'll find that we're indeed just on one horse achieving those two aims. Thank you.
That was brilliant, John. Always love hearing the world that you work in, which is fantastic. And I think for me, health inclusion, we don't always think about that. We understand digital inclusion, but we don't think about those wider determinants until you kind of chat and you touch into them. And I think that's just a really empowering opportunity. Because as I say, it's the things that we don't always think about, know what we know, but it's about what we don't know. So that's always really great to share that. I think for me, I was really shocked about the age of some of those communities in terms of their mortality rates.
Yeah.
I'm sure our audience were exactly the same. You just kind of, oh my goodness, I didn't realise the impact that that can have.
Yeah, I think one of the things that we often talk about in the NHS is our drive for effectiveness and efficiency, and we set targets and thresholds like 95%. And if we can do well for the 95%, then we've achieved, we've hit our aim. But what we do is we constantly further marginalize and exclude those people with often multiple and complex needs. And the drive for efficiency and effectiveness is often about standardization. So if we can standardize a pathway, we can get more people through the system, and we are seen to be more effective and efficient, and the system performance is better. But at what cost? And by excluding people at the expense of becoming more effective and efficient, we actually create more cost and more challenges, and we're doing a disservice to those people who actually need our services more than anybody else. So it's not a plea, is it? It's to say, always work to become effective, always work to become efficient, but never at the costs of people often at the margins of our society who are already often through absolutely no fault of their own, stigmatized and traumatized. And if we can do it well for inclusion health groups, we will absolutely do it well for the wider community.
It leads on. I was thinking about our audience and what they take away from this presentation around inclusion health. What do you think they need to consider? So we've got a variety of people with us, you know, from frontline staff, strategy makers, but also the third sector, which I think play a vital role in that. So just wanted to hear your perspective on that, John.
Whilst recognising the intersectionality, as in the interplay between people being members of multiple groups, I think it starts with just looking at that list of 17 communities and saying, does the work that I am leading enable any of these communities to have an improved experience, or does it improve their access to healthcare? So rather than thinking about a general population, thinking very specifically about particular communities that may be more prevalent in the area, the community that you work within. And I think that if you just start to think that there may be a subset of your population with a particular, who identify from a particular community, if I can get it right for them, I'm likely to get it right for everybody else. So start with that list, notwithstanding intersectionality. I will keep on saying that, but start with that list and have a think. Do people from those communities live in the community that I serve? And if so, is my digital inclusion approach addressing their needs as well as it does the whole population? And that would be a big step forward.
Well, take away that message, our audience,
Thank
please. Listen to John, he's wise. So I guess I always go on about workforce, because one of the biggest challenges, I guess, is getting that clear message through. And we've got really active members on the forum who come and they contribute and they understand and learn from that, which is fantastic. For me, what other opportunities do you think? So, I mean, we've got a quality impact assessment, you know, identifies those characteristics. But I just wanted to think, you know, what training opportunities other than the Boost platform, which is becoming a brilliant resource, are you aware of any health inclusion opportunities for people?
I'm always going to steer people towards the Learning Academy and the Boost platform.
Yeah, great.
And for me, I think an awful lot of the obligation for learning about inclusion and health, particularly for registered staff. So I'm talking about physios, OTs, nurses, doctors. It's a professional obligation. I think that there is something we spend an awful lot of time understanding about the clinical skills and requirements to undertake those jobs, but maybe not so much in understanding the communities that we serve. And I think that that goes back again to the two-horse analogy, that we talk about system performance, clinical skills, providing high quality care. But if we don't actually understand the communities that we're serving and not just manage the demand that comes through the door, but recognizing that we have to change our service offer to achieve improvements in population health, I think that that's really important. Couple of other points on that. We draw our workforce from the communities that we live within. If we know that stigma and discrimination exists in our community, it will exist in our workforce. So I think for those of us that are advocates for addressing stigma, discrimination, marginalization, we have an obligation to role model and to advocate for changes in how we deliver our service. We have to do it sensitively. We have to recognize that we're in an incredibly pressured environment where the top-down messages are improve performance, reduce waiting times, reduce costs, do more with less. But we have a professional obligation to ensure that we don't do that to the exclusion of anyone else.
Brilliant. I'm not going to follow on any more questions. I will just say that we've had some couple of really positive comments. You know, completely. Violet agreed with absolutely everything you said, which is very good because she often can challenge. She's not on the call now, but you know she can have a difference. So I think that's really good. It's obviously resonated with her. We've shared the Boost platform in the chat there so that we're going to encourage people to continue to direct there. And for me, I think it's just a final opportunity. Are there any top tips you want to give to the audience before we move on to our next speaker?
No, I'm just going to direct people back towards the Learning Academy, and people can always get in touch with me. But that's probably enough for me for now.
Brilliant. Well, thank you very much, John, for joining us. I found that really insightful. And I know we'll be asking you to come back at some point, no doubt. So we'll give it a few months, don't worry. So thank you. So we're going to move on to our final speaker, Bethany Taylor. Bethany, I've mentioned earlier, she joins us as the Training and Benefits Lead for the Great North Care Record, and we're absolutely delighted she could join us today to kind of share a bit of an update on, you know, what's in the making of the Great North Care Record. So over to you to share your slides, Bethany.
Thank you. So thank you for letting us be part of today. I'm conscious of time, so I will try and keep it as a really high level overview of kind of what's been going on. So we have just completed an amazing piece of work with Dr. Rebecca Casey and Professor David Wainwright from Newcastle University around the benefits of the Great North Care Record, focusing on an evaluation and effectiveness of the Great North Care Record. If you aren't aware of what the Great North Care Record is, I thought I would give a little bit of an overview. We are the Share Care Record in the North East and North Cumbria region. The Great North Care Record allows for collaboration between trusts, local authorities, GPs, North East Ambulance Service, community, mental health, 0 to 19 services, maternity and hospices. Health and social care professionals access GNCR through their electronic patient record. It has become a vital tool for the professionals as they view it around 1 million times a month. And there is some amazing data being shared. We are constantly expanding on the data that is being shared there. So we thought it was really important to look at some of the benefits that were being shared. We had 3 main objectives throughout this piece of work. So it was to assess the benefits of GNCR by capturing time efficiencies and reductions in duplication across care settings, to explore how shared care records contribute towards improved patient safety experiences and outcomes, as well as supporting them with their decision making, and to identify and support mechanisms for scaling digital transformation through the development of a time efficiency benefits dashboard. So we've had some amazing pieces of work come out from this, and I'm happy to share them throughout today. So we did go through 5 primary types of data input. So we did a survey. We managed to get over 100 responses, which we were really happy with. It was a bit of a push, but we did end up with more than we expected. So that was really good. We also interviewed 15 a range of professionals across the health and care sector That allowed us to create 15-day in the lives. They're amazing. We will be sharing them kind of across our platforms over time as well. And that's allowed us to have a really good insight into how GNCR benefits each different individual within their role. We had a range of workshops which allowed us to co-develop the benefits dependency networks. And we do have an amazing piece that will be coming out that isn't just for GNCR, it can be used across all digital projects as well. It's not quite ready. We're hoping it'll be ready by the end of June. And we reviewed all of our documents, and we worked very closely with One London. They've previously done a similar piece of work, and we used some of their methodology and collaborated well with them. And we used our data usage as well, so a snapshot from November to look at the different data and usage that was happening. One of the main pieces of work that has come out of it is a time saving efficiency piece. So from the survey, we realised that people were reporting saving between 5 to 20 minutes per patient, which obviously if your appointment's only 15 minutes and you can save 5 minutes, that is absolutely amazing. So that was something we really wanted to focus down on, looking at how much money could be saved. Obviously that money saved is then put in, we're not saving it aside, but we are managing to save around 1.5 minutes per access was valued as 75 pence per minute. There will be a big piece of work on our dashboard around this as well. So I'll explain a little bit more in a minute, but we're having a dashboard and this will feature on there as well. We don't want it to kind of look like a massive saving if it's just on a snapshot. So just be aware below is just based on 30,000 accesses per month. And these slides will get shared as well. So hopefully you can have a bit of a better look and understand that further. But it's amazing to see what time can then equate into that money as well. So some of the differences made from this piece of work, specifically through those interviews, we really managed to get a deeper understanding of actually how that is helping those clinicians. So the improved clinical decision making, people said it was invaluable. It was part of their everyday life that they kind of use. It's not just something they might pop into. It changed the way that they kind of provide that care. It made it more seamless for the patients, and people are having to repeat less. So it did just give us some kind of expanded knowledge of how we already thought it was benefiting people. The direct beneficiaries would be the GNCR programme leaders, as well as the frontline staff, mental health care professionals, social care practitioners, maternity teams, and there was many more. Many reported that participation in the evaluation also allowed them to reflect on the workflows, and they also thought, actually, I could use this even better. And we've kind of collaborated and we've maybe put more training into places and put some more plans into place. We've done surveys with certain organisations to see how we can emphasise the use of GNCR more. So not only has it allowed us to understand the impact, it's allowed them to reflect and see how the impact can benefit their colleagues and organisation more as well. We have co-produced the playbook, so this was part of the benefit dependency network. So the playbook and prototype dashboard are now embedded in our future planning and governance. The playbook is still in development. It's going to be a user-friendly playbook and PDF version, but interactive, and it's going to allow you to use the different tools that we use throughout this program in the future as well as part of future projects. So hopefully that will be beneficial. Some of the unexpected outcomes was a dashboard. We have managed to secure some funding to get a new dashboard. We are working on this at the moment. It's going to allow us to basically, people were finding our Excel stats a little bit complicated. Some of them were struggling to use it. At first, it was it's on the website at the moment. Some were struggling to download it. So to make it a bit more inclusive, we're going to have a Power BI functionality, and it's going to be much easier to kind of narrow down your organisation, find the results. It's going to be a much more interactive piece and a lot clearer on how to find that data. So that's a really exciting piece of work that's going to allow it to be a bit more accessible to people. Some weren't kind of utilising the Excel one, and that'll hold all of our dashboard data. So the dashboard data will include our stats, some training stats, and the time efficiency data. We've also just secured some funding to have an AI feature on the website. From the narratives that we had with from the interviews, we found that people needed more support with the training materials, or they needed another way to access those training materials. So we're going to have in the future an AI function on the website where people can type in what they're struggling with or need some kind of focused help with, and it will then pull through all of the different materials available. That's at the very early stages, but hopefully throughout this year, that'll be an amazing project to help make our website more inclusive to everyone. Some of the long-term impacts is that we'll have that playbook as a reference tool for future digital transformation, and just the fact that we're going to have this continued engagement with the team. We've been so grateful to have some amazing ambassadors support us with this as well, and hopefully it'll just keep impacting that digital value as well. Just some of the outputs. So we do have 4 main outputs, which I have mentioned throughout. Obviously, this is a very high level view of the massive piece of work that has happened. And the final evaluation report is just being kind of put into a user-friendly version at the moment. And again, will hopefully be ready by the end of the month. Our benefits realisation playbook, which I've just mentioned, again, is still just being finalised, and again, hopefully end of June. And the dashboard is a bit of a longer term one that will hopefully this year will be ready. And the day in the live narratives we will release over our social media and on the website over time, focusing on some of the amazing professionals that we've worked with. So hopefully we could share some of these in the future, especially the playbook and report, especially since they're going to be ready quite soon. Maybe we could try and get them put onto the Boost platform as well with everything else. But yeah, that is an amazing piece of work, and it's going to be extra exciting when I can share the actual report. But we thought it would be important to show you kind of some of the work that has happened and will be coming soon.
Fantastic, Bethany. It's some time since I was involved. I remember going to a PPIE session on patients, chatting to them in its very early infancy as a project, and it's great to see that journey that it's gone through. I think for me, the dashboard sounds exciting. It's like a way to kind of visualize something at one level, which was really important. And it was really great to hear you talking about it becoming just part of everybody's daily lives. You've really embedded that, and actually they're probably very reliant upon that. How else would they get that information? I always think of a friend who was on a hen party in London, and she has asthma, she's on medication, and she had an ectopic pregnancy and was very poorly, but it was before Great North Care Record was available. We didn't have any access to that information. She was on her own in a hospital, with one member of the hen party who'd come, and it was just scary. But actually how the importance of that patient's journey in that, and I think that's absolutely brilliant. I'm excited to hear about the AI as well. So I wanted to ask a question about the AI, if that's okay. Yes. How has that come about? Because it's a really interesting development, and it's great that you're getting some funding to support that. But we're kind of really still, on the horizon scanning of AI, and people are getting a little bit nervous. But I'm dead excited to see people using it. So I wanted to just hear your journey with that, please.
So it came from kind of the interviews with those professionals, and they were saying, we just need sometimes, obviously they're working 24 hours a day, some of them, obviously they're not doing the full time, but we're only available for certain slots of the day, whereas they can be working those out of hours shifts, and they might be thinking, oh, why is this not working? Perfect example, if you apply a filter on GNCR and you don't remove it, it can apply to the next patient. If you don't know to look for the filter training guide, you might not know what the issue was. So sometimes they said there's an issue, I don't really know what the issue is, so I don't know how to then find the help. So through discussions, we decided if we had something such as a ChatGPT bots kind of in there that could actually say, there's this happening, what does it mean? It would then pull through the training guide, a video on how to remove it, and it would be accessible to them at all times, and it would just support with that training further. It would also give those people that aren't that confident using it. Some people said their colleagues can be a little bit hesitant to use it because you don't want to break anything or you don't want to press any buttons. So if we build up their confidence by having that available to them at all times, they'll then become more frequent users, which will then help them support their clinical decisions and save them time, which will help them provide that better patient care. So it all came off the back of those interviews from this project.
Really good. It's dead exciting to hear, because I guess it's from that demand, isn't it, from you, the people who are using it, and you've come up with an innovative way to be able to tackle that. So I'm quite excited to see that in reality when it comes along. You mentioned about the playbook, and I'm just wondering, are you intending to share that nationally? Because obviously the NHS have got that blueprint kind of programme that they're working on. I was just interested to see whether or not that's just for your own kind of region, or whether or not it's something you could share wider.
No, I think it's happy to be shared wider. It's created as a tool for everyone to use. Obviously, there are some GNCR elements within there, but the tools themselves are there to be used digitally. Yeah, definitely. If the opportunities arise, we would definitely share.
Brilliant. And one of the questions we had from the previous presentation was more about, you know, systems not talking to each other, not being able to get the same view. And Chris Foreman, one of our brilliant forum members, who is a very good knowledge, has shared some information kind of on his thoughts on, you know, how it is starting to connect in the system. And I was delighted because I knew, obviously, presentation wise, you were coming along next to be able to kind of share one of the opportunities where we are connecting that data, which is really important. The final question from me is just picking up again on that training. So you've talked about, you know, developing that AI, but if we've got audience members who want to get updates on Great North Care Record or any training opportunities, how do they go about doing that, Bethany?
So on our website, and I'll share the link in just a second, we have a booking form. It just says book now on the training page, which I'll share the link to. And I run training sessions twice a week that do an introduction and overview, which gives you a full overview of what GNCR is, how to use it, some tips and tricks. It goes through the full record itself. And then we have an upgrade session, which is more for those that are frequent users and just want to know any new functionalities and features that are out. And that's once a week. So the introduction session is 1 hour and the upgrade session is 30 minutes. But I try and do them across the month on different dates and different times, just to try and reach as many people as possible. If there are any teams or departments that wanted training, so if you think, oh, my full team need that, I'm happy to put my email address in as well, and we can arrange some bespoke training for your team and department as well. So plenty of training opportunities there if people are interested.
Brilliant. And as I've said to our other speakers, it's your opportunity. Any final top tips or anything you want our audience to go away and do differently as a result of hearing an update on Great North Care Record?
I just think kind of being aware that it's there. Often you speak to people and they don't know that it is there, and it's there as a tool at the end of the day to help people. And obviously, if all of these other elements, the benefits, the AI bot, the dashboard, and the playbook can help you, then please utilize them. We will be sharing them farm wide, so we're happy to share them on a boost, etc. if the opportunity's there. So please do just utilize what's there and don't be afraid to reach out. It can be a bit complicated at times if you don't really understand it, but that's what we're here for. So please don't hesitate to reach out. We're more than happy to help.
Thank you so much, and thank you for being patient and waiting until you were last. So
thank you.
I'll just very quickly round up our day from today. Bear with me a moment. So we've done our Q&A, just some final notes. So I'd like to, well, personally thank all of our presenters today. I'm sure we'll all agree with me what a fantastic forum it's been. We've heard all about the digital inclusion strategy. It's been signed off at board on the 3rd. So that's absolutely fantastic. Read it, make sure you do something with it and help support its delivery of that moving forward, which has been fantastic. We've then heard really brilliantly from John Quine about the whole health inclusion aspect, but linked into digital inclusion. And I'm hoping you took some things away from that. I certainly did, because you don't always think about those characteristics and don't think about the challenges that those people face. As John articulated, we deal with the 95% who might hit that target, but actually, what about those 5%? And they're probably the people that we need to spend some more time with. So please take some messages away from that, which would be fantastic. And then finally, the Great North Care Record. It's always great to get an update on how we're trying to get that one view of a patient's record and help to increase that patient safety across the system and give real information to clinicians to make an informed decision. So I think we definitely want to have Bethany back in the future to continue giving us further updates. So just to say, we will be sharing the recording with you shortly. We have got some unanswered questions in the chat, which we will follow up and get back to you, just so you've got a full round of responses to those. But we have our next forum. I'm sorry the wrong date is on there, but it is the I can't remember. It's in September and we will send the information out to you. Do apologise, it hasn't been updated there. The link has, because I know I've copied it over. But we will see you in September for the Digital Inclusion Forum and look forward to you joining them. We don't have topic as of yet. We've got a little bit of time to prepare because we miss out the summer, so we've got a little bit longer. But no doubts it will be very interesting. We've had one person reach out already on email to say they'd like to come along and contribute, so we'll let you know soon. Good. I'd like to thank you all for joining us today, especially our speakers, and please have the rest of a pleasant week, and we look forward to seeing you in September. Take care.